Welcome again, everyone. I'm Angie Grover, co-founder and COO of Metopio. Just a quick bit of housekeeping before we get started today. We have a new interactive format we're going to be trying out. So the chat is pretty important because we are going to be sharing data that was curated same day it was released, and maybe you haven't had a chance to look at it. So we're going to give you a chance to look at it with links in the chat. So keep your eye there. We've got a lot to cover in 30 minutes. So we'll have the chat on. Please engage there. If you have any questions or comments, you can also add them there. If we can get to them, we will. If not, we will be sending out the slides, the recording, and any answers to unanswered questions as a follow-up within 24 hours. The audience will be muted. And for those of you who don't know Metopio, we are a platform and a partner who provides data and analytics to automate community assessments and health improvement plans. And our intent really is to enhance your productivity and give you more time to go out into the community and put your insights into action. So let's close that poll. If you haven't taken it one last time, we'll share those results. Oops, I think I clicked off the sharing. So you should be able to see those results. Obviously, population drives a lot of what we do, but everything from income to where you live, these are all the things that we'll be diving into today. All right. So one of the things that I always like to do and center on before we jump into a data presentation is that we know every one of these data points represents a real life, a real person, a real community, and also real opportunities to drive meaningful change. So very excited to introduce my esteemed colleagues. Heather Blonsky is our Vice President of Data at Metopio, and she leads data governance, curation, quality assurance, and methodological integrity across all of our planning initiatives. She has unique experience previously working with the UNC hospitals and the Cleveland Clinic and leading the team that built Vizient's Social Vulnerability Index. She holds a bachelor's degree from Wayne State University in medical anthropology, which I always love to say. I think that's fascinating, and a master's degree in applied statistics from Penn State. Annie Elliott serves as our senior data analyst with us at Metopio and provides advanced analytic expertise supporting our statewide and multi-jurisdictional public health planning, systems assessment, and third-party validation efforts. Her experience includes developing AI-guided clinical decision support tools for emergency medicine, and she spent more than a decade in bioscience and clinical research with a focus on the neuroscience of addiction. She holds a PhD in neuroscience, a master's of clinical investigation, and also a master of data science. So now you see why I'm so excited and so proud to have such smart people on the team who were able to see the release and get it curated so that we could bring you this webinar. So with that, Heather, can you take us into the first slide?
Absolutely. Thank you, Angie. So ACS data, that's the American Community Survey, was released last week. It was the 2024 release, which for the 1 year averages is all the surveys done in 2024. Reported in 2025, slightly delayed. It was actually just about a 40-day delay after the 40-day government shutdown, so not much later than we would expect. We have the 1 year averages and also the 5 year averages, which give you 2020 to 2024 and get you to those smaller areas, the zip codes, the census tracts, and allows us to provide that data at every level you want. We do use both. We do switch between them pretty frequently. But the thing that I'm excited about this year is that we're starting to get out of those COVID years, that peak of 2020, 2021, when things were really changing. We're going to see a lot of what that did to the data, what's sort of a new normal and what's still changing. But really, when we talk about these topics, the 235 that we curate out of the thousands that we could are really the ones that lead to what we can do about healthcare, what we can do about health outcomes, and the context that we need to make those changes in our communities. So if you want to jump right in there, great. So really, any topic that we curate, any data that we put on our website is in this one place, and you can see a lot of detail about what we've done with it. This will pop up with where it's available. That's all those geographies that we include, all the years that we include. And this is one of the things that's great about the ACS. It does go way back in a very consistent style. But we also have exactly where it came from, the table, the details. If you wanted to go do it yourself, I don't recommend it, but you can track it all the way back to the actual data points that we combined. What we do with this is really all those geographies, the stratifications that we need, and then how we can combine it with any other data source we include.
And that is teeing us up to get started with what is that new normal. So you'll see on that last slide, there was a note about 2020 data collection because it was collected during COVID. So there's some questions around that data. But now that we're moving away from that, the new norm, Annie?
Yeah. And that's when we can pull in this 1 year data from ACS and start to look at year-over-year changes. We pulled in work from home for this example. So let's take a closer look at work from home. You can see it's pretty stable until 2021 when we see that massive increase in people who began working from home. Let's label those data points so we can look more closely. Here we're comparing Maryland and Ohio, and it might be nice to pull in some specific counties. So let's look at Cuyahoga County, which is where Cleveland is, and we will look at Montgomery County, which is Montgomery County, Maryland, which is just outside of DC. So those are two urban counties in two different states, and we'll remove the states themselves and the United States so we can get a better view at just those counties. And what we see are two unique patterns. Both have that peak in 2021 expected as people started to work from home, but Cuyahoga County has essentially reached a plateau. And from last year, from 2023 to 2024, there's not very much change. While we still see some potentially ongoing change in Montgomery County, next year, this may plateau. We may see another little drop.
Yeah, and I think this is a really good topic, especially when we talk about what happened during COVID. You see it's very consistent, very similar before COVID. Afterwards, you see this really big difference regionally, obviously over time, but also in context with other data points that we have. I'm not going to share them today, but if you look at the industry sectors that are represented in these locations, Montgomery County is a lot of public administration, professional, scientific. Those are jobs that can work from home, but different policies and different approaches are going to change that number year over year. Where Cuyahoga County has an enormous number of people in healthcare. Cleveland Clinic is there, but other hospital systems too. So those are people who can't work from home, no matter what. You have to be in the ICU to be the ICU nurse. So those regional differences really have a lot of context around them too.
Yeah, and we want you to explore the regional differences. So our first interactive link is in the chat. We have produced national maps so that you can find your county, see how you compare. Just click on it and you'll get that data. We'll go through a series of these, which with each topic that we're doing. And I'm excited because the next topic we're going to dive into is going to give you some data from the Chicago Health Atlas, which uses Metopio's software to disseminate the data to their community. And we're going to talk about SNAP benefits, Annie.
Right. Angie mentioned that we're looking specifically at Chicago Health Atlas here. So you'll notice slightly different screen. If you have a health atlas and you have ACS data on your health atlas, when we import the fresh ACS data, that is automatically updated in your atlas. So you'll see all new fresh ACS data here. We've pulled in SNAP benefits. Let's take a closer look at these SNAP benefits in neighborhoods in Chicago. And you see a typical pattern here of people with higher rates of SNAP benefits and lower rates. But I'd like to use the filter tool to filter for just those top two quartiles. And then I'm going to apply a separate filter, which is Chicago data specifically from the Chicago Healthy People Survey. May have that slightly wrong. And we will also filter here for the top two quartiles. And then we see almost an identical pattern between those two filters.
Yeah. And especially when we're talking about food insecurity, that's a topic that we've been worried about where we get that data. There's been a lot of change in what's been available. One of the things I like about this is we have that SNAP benefit data from the ACS, and we have that local immediate survey data that Chicago Health Department has collected themselves. And you really see they overlap quite a bit. They're obviously not the same question. They're obviously not the same data point, but you do get a leading indicator that SNAP benefits and that more traditional food insecurity of skipped meals really do correlate pretty highly. So we do still have that data, maybe in a slightly different form, but it does coordinate well with what our local customers are doing.
And just like on Metopio, if you go to the Health Atlas via the link we shared in the chat, if you click on any place, you'll get both of those data points. So that's one of the other important things about new ACS data is that you can start to layer it with other topics and see multiple variables on a map to really give you that richer insight as you do your work. So, with that, we are going to jump into some subpopulations and talk about healthcare. And Annie, you're going to take on the young invincibles.
Let's talk Young Invincibles. This is an example of how we've taken an ACS topic and or an ACS table and really approached it in a creative way. So here we're pulling in people who don't have healthcare specifically in that 19 to 25 age group. And this year we've also been able to add sex stratification. So I'm going to show you how we can break it down by male, female, but let's take a closer look here at Collins County. This is a suburban area outside of Dallas. I'm showing that we can look at zip codes and census tracts, but we're not going to focus on that right now. We are going to just stay focused on the county itself. And here we're looking at females versus male in Collin County, and we'll compare it to Texas as well as that Texas rural benchmark. And what we can see that is that across the board, and almost every geography that I looked at, males in this age group tend to have higher rates of no healthcare coverage relative to females, but it's especially pronounced in this case in the Texas rural benchmarks.
Yep. And I think the geography is interesting here too. The more suburban county does tend to have higher rates of insurance, so lower rates of young invincibles without. But there wasn't a very strong pattern across the whole state. It's not one of those measures where you can say, oh, I can see Dallas from here, I can see Houston from here. It does vary quite a bit at that local level. And that's really where things like census tracts and zip codes come into play, because you can have a lot of variability in a small space. It can look a little random, but knowing that your local area behaves this way is what's key.
And Heather, are you going to touch a little bit on the rural benchmarks? Because I know we're really focused with the current administration about rural health and access and who lives there and why did Metopio put together those rural benchmarks?
Absolutely. Now, those are based on the HRSA rural coding. So they're meant for healthcare, but they're also really a good way to say, for those topics that have a strong rural urban difference, that you're comparing to a benchmark that makes sense, that you're not just comparing to the whole country and you know you're in an area that doesn't have any obstetric care. You know you're in an area that's entirely made of food desert. That's not something that's going to change. And so having that benchmark to say, let's compare it against other counties that are similar gives us that rural benchmark. We have one for every state and it comes in handy for these things.
And across every topic where we can aggregate the data
Yes.
in that fashion, right?
Exactly. And that's virtually every topic.
Yeah.
Counties are pretty easy.
Yeah. And it's just to your point, I grew up in a farm town. It is really hard to see disparities or access issues when you're looking at, a smaller community against, say, a Chicago. It kind of, it gets lost in that
It
noise.
does. Yeah. I did want to throw in one other quick thing here about the young invincibles and why this is an important population. This is upstream. This is as upstream as pretty much we get in adults. And so when we're talking about things that go wrong, we're talking about, chronic conditions and complications of chronic conditions. These are the people who are going to have them. And the fact that they don't have insurance right now could become very significant very shortly. It hasn't yet. And so even though we think of them as young and healthy and probably fine, some of them aren't. And this is really kind of a key factor when you're looking at what you can do about all those things that come.
Yeah, and that tees us up for the next topic we wanted to dive into, which is a stratification around disability. Annie, what do you want to show us in the disability section?
We are looking here at disability among 18 to 39-year-olds, and these are all sorts of self-reported disabilities for this topic. But let's take a closer look. We can see that it was starting to increase already pre-COVID crisis, and then we have fairly high rates of disability for this age group. And this pattern is consistent among some of our other disability topics. If we pull in independent living difficulty, we also see a similar pattern. And if we pull in cognitive disability, we also see this pattern. So for an age group that we consider relatively healthy, this is an unexpected pattern. Let's put it that way.
Yep.
We can pull in the bar plot and compare it to 65 plus, which is the age group where we would expect to see a decent amount of self-reported cognitive difficulty or other disability. And I'm comparing here against a rural benchmark and Dane County, which is where Madison is. And then I here just removed all those age stratifications that maybe we don't want to necessarily focus on at this moment. And I think what's interesting is that for some disabilities and in some locations, this 18 to 39-year-old age group is actually exceeding the 65 plus, in this case, in the Wisconsin rural benchmark data, which is really surprising and unexpected and concerning, especially for cognitive disability.
Absolutely. And this is one of those areas, again, where that specificity matters, because this is not true of every disability. There are different classifications. There's vision disabilities, there's hearing disabilities. But these particular ones in these particular age groups are really showing a really interesting pattern, and one that we don't have a solid explanation for. I mean, it could literally be COVID. It could be long COVID, but that wasn't the only thing that's happened in the last 5 years. There are a lot of other things going on and a lot of other things that really affect this age group. It could be just mental health crises that develop into a disability. Lots of different things that this could touch on. And this is, again, an area where you need to know your local space. You need to know what's going on there. You need to know why your neighborhood versus a different neighborhood might behave differently in this particular factor. But again, this is now like core healthcare. This is almost an outcome where, you know, we're getting out of the area of just that context of economics and housing and all the other things that the census provides, and really into like, what is this doing in people's daily lives? I find that fascinating. I could really dig into this data forever, but yeah, this is one of my favorite topics, not because it's you know, it's one that we have solidly pinned down, but because it has a lot of potential here for what we could do with it.
For sure. And I'm monitoring the chat, and it looks like we need to make sure that we get the disability map there. So we'll make sure that we're trying these interactive links, so that we'll get you that disability link up there in just a moment. And I will say we have one more topic to cover, but if there are other questions that you're interested in, go ahead and put those in the chat as we look at one of the other things that you can do with data, which is develop an indice. And so we're going to talk about the hardship index.
The hardship index is an index that we have built with Mentopio's index builder. It's modeled off of the economic hardship index, which has been around since the 1970s. And I'd like to take a look here at North Dakota. And what we see is that there was a slight increase in hardship index even before COVID. So maybe not directly linked to COVID. I want to highlight which topics are used here in the index itself. And let's compare it to the North Dakota rural benchmark. We'll pull that in again. But North Dakota, as you know, is a fairly rural state, and there are only 3 counties in North Dakota that aren't included in that rural benchmark. So let's pull in one of those counties. We'll do Burley. That's where Bismarck is located. And then we are able to see some really interesting differences in hardship index between North Dakota, the rural counties in North Dakota, and Burley. There we go. Now we're ready to look at those bars. I also want to note that for this index, when we update ACS data, we also recalculate this index. So that's something we manually do. If you happen to have an index that's built on ACS data, now's a great time to go in there and recalculate your index and take a look at it.
Yep. And generally speaking, I mean, the thing with indices, the one we did at Vizient, the other indices that have been built for different purposes across the country, a lot of them focus almost exclusively on ACS data. And part of that is because it updates so timely. It is available at so many different geographies, but it is your basic data. It's your unemployment, your income, your age dependency, all of those things that we can get out of a national survey, a national census. And really, I think it's kind of an exciting way to I don't want to say get away from the specificity, but start using a lot of things together to say it's not just poverty, it's not just a food desert, it's not just unemployment. It's how all of those things tend to pile on together in one place. And you'll find, especially with those sort of economically oriented indices, you get neighborhoods where everything is going wrong. Everything has been under-resourced and under-supported. And those are the ones that really stand out in this kind of index. But it's a lot of, it can be a lot of work. It can be a lot of math. I do like that we have a tool for it, and it keeps us from having to recalculate it by hand every time. So very exciting to have.
And what I love about indices, I am the self-acclaimed non-data scientist on the panel today, is that it gives you it helps you communicate one indicator that you can compare across places. But then it also,
Exactly.
the way Metopia is set up, you could then dive into each one and look at which ones are different from place to place. And I think having both of those at your fingertips is really informative as you look at how you want to do your work. We had two questions real quick, and one of them was, and I don't know if we have an index or another example you might want to reference, but somebody asked if you can add your own data to Metopio and then use it with this data. So do you want to touch on that just a little bit?
Sure. Absolutely. Yes. So there are a lot of different ways to add data in Metopio. One is just a user data upload, which is aggregated data just like you would get out of the census, but maybe it's a source that you have specific access to. We can also take on line level data like a survey or claims data or research data in a separate area where it's PHI safe and we're not sharing it publicly until it's been aggregated and sent back over. So yeah, I don't want to say unlimited, but virtually unlimited ways to combine data. And that's really, why this is exciting. It's not just that we have the ACS data. The census has the ACS data, but that we put it together in a way that you can combine it with everything else you do. I mean, we're aiming for, what we can do to really improve health outcomes. And so it really does take all of those pieces, some of which we have, some of which you have, and how we can put them together in a really actionable plan.
Yeah, and
And oh, go ahead, Annie.
I think probably where I wasn't entirely clear was that app list part where I showed you the food stamps and then the people who were skipping meals due to cost. The skipping meals due to cost was actually client data that they imported themselves.
Yep.
That was not data. So that was a good example of how you can use Metopio data and your own data.
Yep.
Yeah, that survey data that often you collect in the community assessment process. Two things I would just add before we get close to wrapping up here is one, we have been running surveys with our clients, and with data disappearance, somebody asked about the county health rankings, and we have worked with them over the years. We do have county health rankings data in Metopio, and they are sunsetting some of their efforts. And while they're doing that, that data is still really important. And at the same time, some of those sources have been at risk this last year. So we've really been working with folks to deploy surveys that fill gaps so that you can have your own longitudinal data. And that really is the benefit of conducting a survey or using utilization or claims or other proprietary data where you can look at community context in addition to your really specific and targeted data. It really does, that's where the magic happens anyway. So,
Definitely.
um, let's see. I'm just checking the chat. Again, I made a couple on my end for having some mismatched titles. When we send out our slides, we will all send out all the accurate links so you can still take a look at your place. We want you to be able to do that. Um, let's see. I understand how to upload our CHNA data that we collected outside of Metopio. So there's you do have the ability to upload data into Metopio, and as with any piece of software, we're always trying to upgrade and make that easier and easier to do, whether that be survey data or other kinds of data. And I will just touch on what those our bonus round for that matter, because we do want to talk to you more about the data that you're interested in. So before, ooh, I almost got to the end without doing that. Hang on. There we go. Sorry. So before we go, the bonus round really is we have a couple of ways that you can engage with us. Three important party gifts, so to speak, around data. So, like I said, you'll get the slides, the links, and the recording within the next 24 hours. If there's somebody that missed out on our discussion today or you want to share with, please feel free to do that. And while we packed as much as we could into 30 minutes, there are 235 topics, so we couldn't go through them all. You may be sitting there thinking about how you want to combine your proprietary data, whether it be that claims data, or surveillance, or surveys, something else, with this new data to inform your work. So, if so, we'd love to chat with you because we do regularly help teams to pair their qualitative and quantitative data with hundreds of local and national sources like ACS, and then use it to complete assessments and reports in minutes, really, rather than months. So if you want to look at another topic or see how that's done, you have an option for that. And then finally, speaking of data chats, this doesn't have to be our last data chat. So I'm really excited that today we are launching our brand new Data Chats podcast series with Annie and Heather and other experts to deep dive into topics facing community teams today. So the one that we're launching today is the true cost of living and how to understand that. But the additional topics we have on tap are things like maternal and child health, food insecurity, financial well-being, and more. And we're really going to dive into what variables do you need to bring together and how do you understand that data to move you forward. So it'll break down what the data actually tells us, how to find it, and then how to use it to drive real community impact. So we'll make it easy to listen in and celebrate this Metopia first. We'll also be giving away a brand new pair of Sony headphones to one lucky winner. So you can follow us on LinkedIn for those details. We want to make sure you can listen to the data chat. And I just personally want to make sure that you know how much we are thankful that you're engaged and patient with us on our new format today. We hope to be sharing more data in our subsequent webinars. So we know your time is valuable, and I really am so thankful and grateful for the work that you do every day to build healthier and more resilient communities. So we're going to leave that up. If there's anything that you need from us, please let us know in the chat or by taking that poll. And we hope you have the great rest of your day. We're looking forward to seeing what you do with the ACS data. Thank you so much.